Good afternoon and welcome to today's topic on glioblastoma. Where are we now? My name is Donna Avanecean. I'm a nurse practitioner in neuro-oncology at the Hartford Healthcare Medical Group. I hope you enjoy today's presentation. I do not have any relevant relationships with any commercial interest organizations, nor do I have any other disclosures. A little bit about myself. I have over 30 years of neuroscience experience. I've been an APRN since 1995. My major areas of interest include complex vascular disease of the CNS, epilepsy, neuroendocrine, and brain tumors. I've both presented at the national and local levels on multiple neurological topics, and I've served as author in multiple textbooks on various neuroscience topics. I'd like to begin today's discussion by reviewing the epidemiology of glioblastomas. Although I, in my practice, see a tremendous amount and even have seen over the last couple of years a significant increase in the number of GBMs that are newly diagnosed in the state of Connecticut, where I'm from. But the facts still show that GBM is the most common primary malignant brain tumor across the United States and in most European countries. GBM comprise 16% of all primary brain tumors and CNS system neoplasms, and 77 to 81% of all high-grade gliomas. So out of all of the primary brain tumors that can occur, GBM remains the highest in incidence. The average age-adjusted incident rate of GBM, depending upon the literature you look at, can be anywhere from 3.20 to 4.64 per 100,000 population. GBMs account for approximately 1.4 of all cancers and 2.4 of all cancer deaths a year in the United States alone. There are approximately 10,000 new cases of GBM each year and 4,000 of grade 3 gliomas, which we'll be discussing a little later on in this lecture. There is, in multiple studies that have examined gender differences and occurrence of GBM, a higher incidence of GBM occurring in the male population. It is the most highly malignant primary CNS tumor. It originates from supportive glial cells, therefore called glioma. Rare metastasizes to other parts of the body, although we have seen this in the spinal cord and even in the abdomen. And in those cases, the latter occurred in a patient who had a VP shunt placed, and the seeding most likely occurred through the CSF. There are two types of glioblastomas. There are primary GBM, which accounts for approximately 90% of all GBMs, and secondary GBMs, which only means that the GBM has developed from an atrocytic or oligodendroglioma. And we'll be talking about this a little bit later on in this lecture. The median age of onset in primary GBM patients is approximately 62 years old, and as early as 55. But I have to tell you that in our practice, we have seen folks as young as 35 and even 33. In those patients diagnosed with secondary GBM, meaning those patients who probably either had a lower grade astrocytoma or even an oligodendroglioma, those patients are usually presenting at approximately the age of 45. Second GBM, as you can see, is usually seen in the younger population. Anaplastic astrocytomas are usually, those patients are around the 50 to 51 years of age, and anaplastic oligodendroglioma usually will present at approximately 48 years of age. Know this though, high-grade gliomas can occur in all ages, including children. It is exclusively, as I've said before, occur in the brain, but can appear in the brainstem, cerebellum, and even the spinal cord. Those gliomas of a lower Hu grade can recur, progress, or transform, referred to as a second GBM. Outcome survival, despite some of the advances that have been made in this disease, and despite the multiple advances that have made in other types of cancers, the outcome survival for GBM patients remains very poor. The majority of patients' outcome survival rates can be as high as 2.5 years. There is less than 5% of the population who do develop GBM who will survive 5 years or greater. The mean survival rate can be anywhere estimated from 15 to 18 months, and this is despite very aggressive management. So what are the risk factors for developing a GBM? Well, it's not that clear. There have been multiple efforts, multiple studies, and to date, no one risk factor can we point to. We have examined, or they have examined, environmental and occupational exposures, but unfortunately, these studies have been inconclusive and underpowered. Examination into pesticides, vinyl chloride, smoking, petroleum refining, and synthetic rubber also proved to not have a direct correlation. As you know, the use of cell phones has also been raised as a potential risk factor for GBM, but to date, this has not been proven. Prior history of head trauma, infections have not been proven to cause brain tumors, but actually may be helpful in preventing progression. And neurofibromatosis. This is probably the only disease that has been known to be linked as a direct risk factor for development of GBM. One of the major risk factors of GBM is something called Lee-Fumeni syndrome. It was first described by Frederick Lee and Joseph Fumeni in 1969 and was first associated with sarcoma and other diverse tumors, including brain tumors. It is considered to be an inherited autosomal dominant gene. Patients with Lee-Fumeni syndrome tend to develop cancers earlier than would be expected. So in a lot of our patients who have gone on to develop GBM at a very early age, we will assess for other syndromes such as Lee-Fumeni as well as Lynch syndrome, which is also a syndrome that predisposes individuals to developing cancer at a much younger age. I always like to begin a topic by examining the historical perspectives of where we have been in the treatment of this disease. So glioblastoma was actually first discovered in 1865 by a scientist by the name of Rudolf Virchow. And he first discovered glioma as a glial tumor. It has a very long and prolific life, hundreds of different types of clinical trials, outcome survival rates dating back to the 1960s, documented 6 to 18 month outcome survival. So as you could see, we really have not made a tremendous gain in outcome survival rates, despite all of the advances in cancer treatment. Radiation therapy, along with surgical resection, was first used dating back to the 1960s and 1970s. And even with the addition of XRT, it only increased the survival rate by 2 months. So let's take a further examination about what was available to folks back then in the 60s and the 70s. Well, surgical resection as early as the 1960s was recognized as beneficial, although even back then, neurosurgeons still treated their patients with very conservative and supportive treatment. Most patients back then, and including the 70s when I first started nursing, patients were basically told to go home, get their lives in order, and to prepare for an early death. However, in various studies looking at gross total resection versus biopsy, they did soon discover that those patients that underwent gross total resection doubled their survival rates by anywhere from 11 to 12 months. If, of course, this was very dependent on where the tumor was located. So in those areas that were deemed to be more eloquent, such as speech centers, motor strip, sensory strip, brainstem, the ability to, at least back then, provide gross total resection was not there. They did not have the advances in the microscopes that we have now, and some of the other abilities that we have now. What they soon discovered as time progressed is that surgery plus the use of radiation and chemotherapy, and multiple chemotherapies had been attempted, improved the median survival rate to up to 14 months. Now, radiation therapy was started, as I've said, starting back into the 1960s, and various dosages were employed. So when they used 60 gray, they noted that the median survival time was increased by 6 months. 6,000 rads of whole brain RT increased 6-month survival rate compared to that 2 to 3 times compared to that of the control group. The unfortunate thing is, and as we know, that the long-term effects of whole brain radiation therapy can result in multiple cognitive deficits, damage to the cerebellum, which then, of course, has its own issues. Within the field of radiation oncology, various radiosensitizers had been used, including mesonidazole, metronidazole, but unfortunately, despite the adding of these radiosensitizers, the increase in median outcome survivals did not increase. Other things that were examined were things such as alterations in the XRT regimen. Unfortunately, again, no improvement in median outcome survival was achieved. They tried things such as dose escalation to up to 60 gray, hyperfractionation or accelerated superfractionated XRT. So you give small amounts more frequently. Brachytherapy, which involved directly implanting radiation seeds into the tumor bed once a tumor resection had been accomplished, whether it be a gross total resection or a near gross total resection. Other agents were used, such as neutron versus photon boosts, radioactive targeting agents, and stereotactic radiosurgery with linear accelerator or gamma knife. Unfortunately, again, none of which proved to increase outcome survival rates. Chemotherapy, which is the mainstay, including today, of our treatment, multiple, again, agents had been examined, such as nitrosourea agents, including systemic BCNU, demonstrated marginal improvement in outcome survivals by 2 months. Other nitrosourea agents, including CCNU, which we actually continue to use, also demonstrated some improvement in outcome survivals. Universally remained the standard of care for adjuvant chemotherapy up until the 1990s. So the only thing that was really available to patients with this diagnosis was CCNU, which is fairly tolerated. Another agent that was derived was the gliadel wafer, which is essentially BCNU. And this was implanted at the time of surgery. And again, whether that was a gross total resection or near gross total resection. And this demonstrated in studies to increase median survival rates of up to 2 months. In 2005, however, there was the game changer, and this was the introduction of temozolomide, which is an alkyliding agent. There was a single study conducted by Stupp et al., and this clearly demonstrated the benefits of temozolomide. They further discovered that when temozolomide is given concomitantly after surgical resection along with XRT for a total of 6 weeks, followed by an adjuvant therapy of up to 12 weeks, could increase long-term survival rates up to 3 years. So for the field of glioblastoma and neuro-oncology, temozolomide was the biggest game changer that they had ever witnessed. As I've mentioned, overall, the survival rates remain poor, 14 to 16 months. In patients with grade 3 gliomas, survival rates are primarily dependent on the histology, but on average 3 to 5 years for an anaplastic astrocytoma and 15 years for an oligodendroglioma. The greatest prognostic factors in patient survival rates include their performance on Karnofsky Performance Status Scale and the histology of the tumors. But where are we now? I'd like to begin by presenting two cases. The first case is Mrs. CR. She's a 58-year-old woman who initially presented to an outside hospital in July of 2016 with chief complaint of unremitting right-sided headache, left visual field disturbances described as flashes, decreased peripheral vision in the left eye, spinning in lights in the left visual field, episodic and not associated with any other seizure-like symptoms. She at that time had no other motor or sensory symptoms. Unfortunately, her visual disturbances continued to worsen, hampering her ability to drive. Her headaches progressively worsened and were associated with nausea, but no vomiting. In September 2016, she finally underwent an MRI demonstrating a tumor within the right temporal occipital region. At an outside hospital, a biopsy was performed, and the pathology at that time demonstrated an anaplastic astrocytoma, WHO grade 3. Unfortunately, because there was insufficient tissue sampling at the time of biopsy, no molecular or genetic testing was able to be performed. This is her initial MRI of the brain. So just for orientation, we have the left hemisphere, the right hemisphere, and she had two distinct tumors, one in the right temporal lobe with a lot of edema, and in the right occipital lobe, which would explain her visual field symptoms and disturbances. There's a lot of edema associated with this imaging study. And this was her FLAIR imaging. I wanted to be able to demonstrate some of the key indicators of a GBM on MRI, which includes a lot of edema, and there's usually a center core of necrosis that is seen commonly in patients with GBM. She was eventually started on chemoradiation between October 2016 and completed a 4-week cycle in November of 16. After 2 cycles, her MRI demonstrated questionable progression. This was in January of 2017. In March 2017, she also developed generalized weakness and headache. An MRI was then performed, which continued to demonstrate progression. She then, and this is when she had then started getting her care at our organization. She then underwent a resection in March of 2017. The final pathology at that time demonstrated an anaplastic astrocytoma with necrosis, treatment effect. And what the treatment effect means is that there was evidence of radiation necrosis and, of course, the chemotherapy, but there was also evidence that there was true disease progression. The EGFR gene amplification was detected in 92% of the cells. At that time, we believe that she failed temozolomide, and a decision was made to start her on CCNU, which she received for the months of May and June. In July 2017, she underwent a repeat surveillance MRI imaging, which continued to demonstrate progression of disease with new areas of enhancement. So now, this is her imaging as she starts to progress. There was continued clinical deterioration during this time, worsening visual field deficits. She began to develop neglect. And you can see by this MRI imaging that now the tumor has significantly progressed. She continued to decline neurologically, as I've stated, with increased left field cut, neglect, confusion, poor cognition, and short-term memory loss. Her chemotherapy regimen was then changed to bevacizumab, 10 milligrams per kilogram IV every 2 weeks. There was some discussion at that time as to whether or not she would be eligible to enroll in a trial. And in October 2017, which is what we're looking at right now, her MRI demonstrated continued progression of disease, and now there was evidence of extension into the left hemisphere. So now there's evidence of multifocal disease. A decision at that time was to add irinotecan, 125 milligrams per meter square IV every 2 weeks. And this would be in addition to the bevacizumab that she had already been receiving. The patient had already been placed on dexamethasone at this time, and we continued that as such. Unfortunately, there was continued rapid neurological deterioration despite the treatment with bevacizumab and irinotecan. She was then considered to be a chemotherapy failure. We then began discussion of hospice with patient and family, and the patient was deceased on December 23rd of 2018. So again, this is some of the imaging that just continued to show. This was what it looked like in November and December when she was finally placed on hospice. Now, the second case presentation presented a little bit differently. She is a 62-year-old right-handed woman who in June of 2017, she had presented, she was riding her pony. She jumped off when the pony started speeding out of control. Unfortunately, she fell, she hit her head, sustaining a closed head injury, and she wound up sustaining a fracture of the left ankle. She never lost conscious awareness. There was no signs of concussion. She was brought to the emergency room, CT scan demonstrating tumors of the right frontal lobe. She then was admitted, underwent MRI imaging, demonstrating extensive tumor involving the right temporal and frontal lobes with enhancing masses. There had never been any prior seizure activity observed. There was a fall 2.5 years prior to this one after falling off of a horse. At that time, she sustained a neck fracture and concussion with one episode of transient confusion. MRI imaging at that time had been performed and CT scans had been performed at that time, and there was no evidence of disease. Her imaging from that initial admission shows 2 distinct tumors, both with that central necrosis that I mentioned before. There is extensive swelling noted around the tumor. On June 13th, she underwent a subtotal resection of both lesions. Post-op imaging unfortunately revealed an acute infarct within the right caudate and frontal corona radiata. although she did do extremely well from that. Final pathology demonstrated a glioblastoma with a MIB of 15 to 20% in the right frontal tumor. And the tumor that was taken out in the temporal region, the MIB was demonstrated to be 40%. So these tumors, both glioblastoma, were behaving very differently. The tumor in the right temporal area was deemed to be more aggressive, or rapidly more cell division was occurring. She was also, on further pathology reports, found to have an IDH1 wild type and MGMT promoter methylated. And soon we're going to be discussing what the indications of having these molecular profiles are. Her neurological examination, postoperatively, she had issues with delayed recall, evidence of a left homonymous hemianopsia, mild left hemiparesis, an ataxic gait secondary to left lower extremity weakness. She was overall tolerating chemotherapy well. However, there was persistent nausea, vomiting, generalized fatigue, but we were able to get her through her treatment. She initially, after her surgery, underwent 60 gray 33 fractions of XRT with concurrent temozolomide at 75 milligrams per meter square. She completed, after that, 6 cycles of adjuvant temozolomide at 110 milligram per meter square every 28 days for 5 days. The standard dose is usually 150 milligrams per meter square every 28 days for 5 days. However, this patient had persistent nausea and vomiting, both with the concurrent doses. So we were never able to prescribe the full dose of temozolomide, but we were able to get her through the 6 cycles. She underwent surveillance MRI every 2 months, which fortunately for her were essentially stable. During this time, she and her husband had done extensive investigation. She was started on a ketogenic diet. She refused any steroids. Their belief was that steroids would actually enhance tumor progression. This was her imaging in November 2017, which essentially, even though there are some flare changes here, there is no evidence of tumor whatsoever. The margins within her tumor bed are excellent. Unfortunately, in January of 2018, she started to decline. At that time, she had already completed her 6 months rather of temozolomide and had been off all chemotherapy. A decision at that time was to start her on a combination of CCNU and bevacizumab. The bevacizumab in this case was used, one, to treat the tumor, but also to treat the swelling that was associated with the recurrence. As with the temozolomide, we had to reduce the dose of bevacizumab as she did not tolerate it. The usual dose for bevacizumab is anywhere from 7.5 to 10 milligrams. We had tried her on the 7.5. She did not tolerate it and was reduced to 5 milligrams per kilogram every 2 weeks. In November 2018, through her every 2 months surveillance MRIs, once again, a question of disease progression was being raised, and the patient had now developed a left hemiparesis. Surgical options were discussed with both the patient and her husband. They refused. She continued with imaging every 6 weeks to 2 months. She presented in January of 2019 after being found unresponsive by her husband. She was admitted. She was treated with steroids at that time and mannitol. And unfortunately, was pronounced on January 4th of 2019. So this brings our discussion to how do patients present with GBM? Well, it's varied. And a lot of these patients, their symptoms go unnoticed, unrecognized. And by the time they do present, the tumors are quite large and unmanageable. Now, usually patients will present depending upon where the location of their tumor is. They usually and can present with any combination of seizures, headaches, or focal neurological deficits, depending upon location. The diagnosis is simple. It's made through imaging, surgical biopsy or resection, and pathology. The majority of gliomas are located within the supratentorial region. There are a small portion of those that are located and arrive from the brainstem, and rarely do you see GBM occurring in the cerebellum. The cartoon on the left is demonstrating what a typical GBM hallmark looks like. Again, the central necrosis with surrounding edema. And this is what the correlation looks like on MRI imaging. So what has changed in the treatment and management of GBM? So I'm going to break this section of the talk into looking at imaging advances, treatment advances, and surgical advances. We'll start off with imaging advances. So needless to say, the development of MRI in the neurosciences was a game changer. But more importantly, for brain tumors, advanced diffusion-weighted imaging capabilities became a game changer for the diagnosis and discrimination of types of primary brain tumors, more specifically between glioblastoma and CNS lymphomas, which prior to the advent of the diffusion-weighted imaging were very difficult to determine the differences because their appearance looked very similar. The addition of perfusion-weighted imaging has some controversy. Some cancer centers use it routinely. In our center, we do not use it routinely. We use it sometimes if there is a question of true progression in disease, but basically it can be used to monitor clinical effectiveness of anti-angiogenic drugs such as bevacizumab. How it works is that it measures the relative regional cerebral blood flow. And in patients who've had a drug response to bevacizumab or to whatever treatment we're employing, you're going to see that the regional cerebral blood flow in the area of the tumor bed will be decreased. If the regional cerebral blood flow to the area in question is increased, this correlates with EGFR amplification and may have prognostic and treatment monitoring applications, meaning that the tumor is progressing and growing at a rapid rate. PET scan, although not used routinely in the diagnosis of GBM, can again be used in differentiating GBM from CNS lymphoma, which, as you can imagine, is treated very differently. Now, we've been talking a lot about different types of primary brain tumors. And the World Health Organization classifies brain tumors within the CNS, which first was done in 2007. Now, historically, brain tumors were only classified by their histiogenesis, their cellular makeup or phenotype. And in 2016, the World Health Organization reclassified tumors of the CNS. And not only did they look at them from a histological standpoint, but also from a molecular standpoint. And so here's an example of various types of primary CNS tumors in their pathological appearance. So these are the astrocytomas, oligodendrogliomas, and glioblastoma. And what you should notice is that the GBMs, there is a lot of hypervascular cellularity. The amount of cellular division is much higher than that of the astrocytoma or even the oligodendrogliomas. So as I've stated, so the use of phenotype and genotype parameters were now in 2016 being used along with histogenesis. And the goal of all of this was to yield more biologically homogeneous and narrowly defined diagnostic entities, thus increasing diagnostic accuracy. The reclassification also, the goal was to improve patient management and also to help in determining prognosis and treatment response. So this is the 2016 World Health Organization grading system of all primary CNS system tumors. And the reason why I keep stressing primary CNS tumors is, as you are all aware, there are multiple cancers such as lung cancers, renal cancers that can, and breast cancers that can metastasize to the brain. Those types of metastases do not fall under the World Health Organization grading system. Those tumors that occur as a result of metastases from breast, lung, or even renal are usually of the same makeup of the primary cancer that the patient has. So just to go over briefly, grade 1, there's usually a low proliferative potential. These tumors are usually discrete in their appearance, and there's a possibility of cure with surgical resection. In those patients with grade 2 primary CNS tumors, these tumors tend to be more infiltrative. They have a low mitotic index, but often recur and may dedifferentiate to higher grade lesions. Grade 3 tumors have increased cellularity, higher proliferative index, and tend to be polymorphic. So they start to lose that discrete tumor appearance, or cellular appearance, I should say. In grade 4, they tend to be hypercellular, hyperproliferative index. They're highly pleomorphic. They have a bizarre appearance, as we saw in the slide previously, with the appearance of endothelial proliferation, necrosis, which is really the definitive finding. So anytime you are looking at a pathology report, just looking at all of these adjectives, if you will, to describe these tumors, these are the hallmark of GBM. Now we can further divide glioblastoma into 3 subgroups. You have the IDH wild-type GBM, which includes giant cell GBM, gliosarcoma, and epithelioid GBM, IDH mutant GBM, and GBM not otherwise specified. And again, we're going to be talking a little bit more about what all of this means. So again, to recap, the WHO classification for CNS tumor diagnosis consists of a histopathological name followed by the genetic features. Example, oligodendroglioma is the histopathological name, IDH mutant, and in this case, because it's an oligodendroglioma, one of the genetic features that is very unique to oligodendrogliomas is the 1p19q co-deletion. For those tumors lacking a genetic mutation, the term wild type is given, such as in the example of glioblastoma IDH wild type. So genotype trumps phenotype. So now we're going to begin our discussion on GBM molecular pathophysiology. And the three things that we're going to concentrate on today in regards to this are IDH, MGMT, and EGFR. So let's begin. Epidermal growth factor receptor. The EGFR amplification can correlate with survival and prognosis. So those tumors who are found to have the EGFR amplification tend to be resistant to drugs and radiation, which is not good. So when we see patients who have this amplification, we already know that their prognosis is going to be less than those patients who do not have the amplification. And why is this? Well, having the EGFR makes the environment, the tumor environment, more hospitable to tumor growth. It's one of the most common drivers of GBM progression and found in nearly 40% of all cases of GBM. It's associated with cell survival, angiogenesis, and decreased time to progression. The main EGFR receptor is EGFR-V3. Monotherapy and combination of other EGFR targeted therapies initially demonstrated to be promising on initial trials. So these were agents such as bevacizumab and others that were targeting the specific EGFR. Unfortunately, to date, the studies have failed to demonstrate any increase in survival rates. Other pathways that have been observed in patients with glioblastoma include the P13K, mTOR, PDGFR, VEGF angiogenesis, the Hedgehog GL1, and there are therapies now that are looking to target these pathways that appear to be somewhat promising. So some of the EGF targeted therapies that are used vastly in other types of cancers, including gefitinib, which is used for locally advanced and metastatic non-small cancer of the lung. Erlotinib or Tarceva is used in metastatic non-small lung cancer. Cetuximab or Erbitux is used in squamous cell carcinoma of the head and neck for both recurrent or metastatic disease. Lapitinib is used in advanced and metastatic breast cancer, HER2 positive, who have failed other drugs, and panitumumab, which is used in colorectal cancer that has failed other therapies with metastatic disease. In our practice, we are now using the Tarceva and the lapitinib on our patients who have the epidermal growth factor receptor. To date, we have not had any successes. So now we'll move to the second profile that in GBM, and that is the IDH mutations. We keep talking about IDH1 and IDH wild type. What does this mean? Assessing for IDH mutation has become now the standard for diagnostics. Anyone who is having any pathology on any primary CNS tumor, the IDH mutation will always be reported. There are two types that are observed in glioma, IDH1 and IDH2. And what studies have shown is IDH mutations are early events in gliomagenesis and remain present even throughout tumor progression. It never changes. If you are an IDH wild type in the beginning of your disease, you will be an IDH wild type at the end of your disease. IDH mutation occurs in all grades 2 through 4 but are absent in other primary brain tumors, such as meningiomas, polycytic astrocytomas, ependymomas, and such. They occur in about 70 to 80% of all adult grades 2 through 3 glioma cases and 5 to 10% in GBM, in particular in those patients who are less than 50 years of age at the time of their diagnosis. So what is the clinical significance of IDH mutation? IDH mutated tumors have improved outcome compared to non-IDH mutated tumors of similar histopathological grade. So having an IDH1 versus an IDH wild type, those patients who are IDH1 or 2 will have a better outcome survival than in those patients who are deemed to have IDH wild type. The IDH mutation is also used to identify patients that will benefit from chemotherapy and to radiation therapy. Now, the biggest one that we look at, and probably one of the most telling of molecular factors, is the molecular prognostic, or MGMT. So what does MGMT mean? So MGMT is a DNA repair protein that reverses damage induced by alkylating agents such as temozolomide. Methylation of the MGMT gene promoter results in decreased expression of the enzyme, potentially rendering the cells more susceptible to alkylating agents. So what does that mean in plain English? If a patient who has a GBM, whether wild type or IDH1, and has a methylated MGMT, that patient potentially will be more receptive to the temozolomide and to radiation therapy than those patients who do not have the expression or are unmethylated. So what does it mean, wild type versus IDH mutant? So going back to the 2016 CNS World Health Organization, as I've stated, it divided glioblastoma into 2 further categories: the IDH wild type, which accounts for 90% of all cases, and frequently with clinically defining tumor as a primary GBM or a de novo GBM. This was not a astrocytoma that grew into an anaplastic astrocytoma into a GBM. This is a de novo glioblastoma. And you see this usually in patients 55 years or older. Glioblastoma that are IDH mutant, about 10% of all cases, corresponds closely to what's called the so-called secondary GBM. So this started off as an anaplastic astrocytoma, an oligodendroglioma, and has now grown up in its adulthood to be a glioblastoma. And this was the case in our first case presentation. That patient started out as an anaplastic astrocytoma, and it progressed to a glioblastoma. And we do see this quite frequently. Okay, so we know the molecular makeup. We know what some of the presentation are. Now let's look at some of what the current treatment strategies are and what some of the guiding principles are. So we're back to the first thing that we talked about initially, and that's surgical resection. So we compared that. We knew that in the 1960s, we recognized that the more you were able to get out of the tumor, the better the outcome survival. Well, that still holds today. So the goal is always for maximal surgical resection. There have been multiple retrospective studies that have confirmed the therapeutic effects of gross total resection of tumors. The overall survival is extended in those patients who do undergo gross total resection. And in those healthcare centers who have the ability to use certain markers, such as the fluorescent marker 5 aminovolinic acid while operated under a blue light in the OR. This agent, it can assist the neurosurgeon in achieving a gross total resection. So basically what it does is it lights up the tumor in a pinkish color, and the neurosurgeon is able to identify healthy cell from unhealthy cell, and does allow for a better, if you will, gross total resection. When not possible to achieve maximal surgical resection, at least a near total resection. And if that's not possible, then at least a brain biopsy with enough tissue for pathology and molecular markers. And that can't be stressed enough. You know, a lot of times insufficient pathology is obtained or tissue pathology is obtained, and all you get is the histiogenesis or the histological makeup of the tumor. But as we now know, the molecular markers are what are essential in the treatment of these tumors. Chemotherapy, unfortunately, because of our wonderful blood-brain barrier, which does protect our brain, very few chemotherapy options are out there for patients with GBM. Many of the available chemotherapy agents cannot pass through the blood-brain barrier. And in those agents that have been identified that can cross the blood-brain barrier, they've been challenging and not proven to be effective at all in the treatment of GBM. Chemotherapy can either be given prior to surgery, concurrent with radiation, or as an adjuvant to therapy. And I don't want to confuse you at this point, but we have actually given patients immunotherapy prior to their surgery, and then they receive it afterwards. But that was actually as part of a clinical trial. And that is an ongoing trial to date. Delivery options of chemotherapy include oral, IV, intraarterial, intrathecal, or even intratumoral. Again, our discussion, of course, reverts back to temozolomide, and we already know that the 2005 landmark study demonstrated the first drug to demonstrate effectiveness against GBM. We know it's an alkylating agent. It works at damaging the DNA of the tumor. Some major side effects include bone marrow suppression, primarily white blood cells, platelets, neutrophils, lymphocytes, constipation, nausea, vomiting, and fatigue. Overall, though, this is an extremely well-tolerated chemotherapy, as chemotherapies go. Standard treatment. In 2005, the standard of treatment for GBM included RT with temozolomide, followed by 6 cycles of adjuvant temozolomide. The average survival rate, 14.5 months, with a 2-year survival rate of about 27%. In 2015, standard of treatment was adopted for GBM, which included XRT, followed by, with concurrent temozolomide, followed by adjuvant temozolomide for 6 to 12 cycles. And in addition to this, tumor treating fields called Novo-2TF or Optune were also introduced. And with the combination of this, the average survival rate at 20.9 months, there was a 2-year survival rate of 43%. And this included maximal surgical resection prior to commencement of therapy. So what is the treatment? Again, and I've said this, I know, a few times already, but after a surgical resection, whether it be gross total resection or biopsy, it will be followed by radiation plus temozolomide for 6 weeks. Radiation They will receive 60 gray 5 days a week. They take concurrently temozolomide 75 milligrams per metered square, 7 days a week through the 6-week period of time. After 6 weeks, the patient has a 2 to 3 week chemo break, and an initial MRI is then performed. That serves as a new baseline after treatment. The patient is then started on adjuvant temozolomide, anywhere from 6 to 12 cycles. It depends really a lot of times on that Karnofsky performance scale, which is a scale that determines independence and ability to take care of oneself. So in those patients who are a bit older, we may only consider giving them 10 cycles versus in a younger population, we would push for the 12 cycles. And there are those older patients where we have successfully pushed the 12 cycles and they tolerated the temozolomide extremely well. The baseline dose that we start off with is 150 milligrams per metered square, and we increase it to a maximum of 200 milligrams per metered square. Again, 5 days, every 28 days. Patients undergo MRI every 2 to 3 months. In most centers, it's around every 2 months. So what about those patients that then present with progression? What is the standard of treatment? Well, unfortunately, there is no standard of guideline for GBM progression. And depending upon the center you work, approaches to this may vary. In some centers, the patient may be rechallenged with temozolomide for about 6 cycles. In my organization, our feeling is that this was a temozolomide failure, and we're not going to continue something if it failed. We may revisit it at a later date after other chemos or immunotherapies have been employed. In some centers, including mine, the addition of bevacizumab, which by classification is a monoclonal antibody that works against vascular proliferation and therefore starves the tumor of blood supply, directly works against VEGF. So that directly works against those people who have the EGFR amplification. But what are some other agents and combinations? There's bevacizumab with CCNU, with an overall outcome survival increased by 12 months. Irinotecan, this particular chemotherapy is not well tolerated. It can be used either as a monotherapy or in combination with bevacizumab. It's used in a lot of other types of cancer. It has fallen in favor, it has fallen out of favor, but overall, at least in our center, it is not our first go-to drug or chemotherapy, if you will, when there are signs of progression. PVC, which is procarbazine, CCNU, and vincristine. This many times is used actually in patients with oligodendroglioma. It has also been tried in patients with GBM. Again, it's not our first go-to in progression. And as I've mentioned prior, other EGFR targeted agents that I reviewed prior. Now, immunotherapy in cancer, as you know, has made leaps and bounds and has, in some cases, been game changers for the treatment of certain cancers, specifically lung cancers and, of course, melanoma. But what is the role of immunotherapy in patients with GBM? This is what we know about GBM and whether or not immunotherapy could be considered. We know that GBMs are associated with 3 overlapping pathways. We know that there's ongoing research efforts to inhibit these various signaling pathways. We also know that there is no single molecularly targeted agent that has proven to be effective. The hypothesis is that molecular heterogeneity of GBM renders emerging therapies that are now used in other types of cancer ineffective. These tumors, these GBMs, are a lot of times heterogeneous, from a molecular standpoint, are heterogeneous. They're not homogeneous. So you may be targeting one part of the molecular makeup of the tumor and not targeting another. And this is what has made treating these tumors almost impossible. In recurrent tumors, the molecular profile changes from the original compounding treatment. The tumor is constantly evolving. And in recurrent tumors, they're described in the literature as ever-evolving molecular landscape. So what are some of the immunotherapy strategies that can be used or have been studied in patients with GBM? Years ago, the role of cytokines was used more so in the form of interferon, high-dose IL-2. In fact, in the late 80s, early 90s, cytokines were developed using IL-2 and were placed into the tumor bed of the patients with GBMs. But unfortunately, these did not prove to be very successful. Various vaccines, such as the EGFR-5/3 vaccine, several studies examining the vaccines targeted at this also were inconclusive, but there is further investigation ongoing. Other immunotherapy strategies that have had various successes in all types of cancer include checkpoint inhibitors, adoptive cell transfers such as CAR T cells, and there are multiple trials right now targeted at identified pathways in which these immunotherapy strategies might be employed. So as you all are very well aware that many years ago, there had been a lot of publicity around the use of the vaccine. So Duke University were the real spearheaded in this treatment modality. And they used the poliovirus therapy for glioblastoma, and their initial in their phase 1 trial demonstrated long-term survival rates of 21% as far out as 3 years from the time of diagnosis. Since that time, other vaccines have been utilized, including the herpes simplex, and many other virus or vaccines have also been employed with marginal improvement in outcome survivals. So what are some of the other emerging treatment strategies? Well, there's still further examination in looking at monoclonal antibodies. Again, these prevent receptor signaling by disrupting downstream receptor activation. Currently, bevacizumab is one of the mainstays that is used, which inhibits vascular growth of the tumors, VEGF. AMG 595 directly affects EGF5/3 receptors, but only in small populations of patients with GBM. And to date, there are other monoclonal antibodies that are in study examining their effectiveness in the treatment of patients with GBM. Innate immunotherapy is another area of treatment that is being looked at. And this is the re-engineering of a patient's innate immune system to combat their own GBM tumor. Oncolytic viruses, I've already mentioned, replication incompetent except in specific cell populations such as tumors. Selected viruses find their host cell through specific marker identification. The virus then undergoes a lytic expansion leading to cell destruction. That is the hypothesis of how these oncolytic viruses work. Once the tumor cell population is eliminated, the patient can be treated with antiviral medication, such as herpes simplex 1, which is one of the ones that is being explored. We did have one patient that entered into this trial, and unfortunately, after receiving her treatment, the tumor actually exponentially grew, and she died within months after receiving the virus. Other emergent treatment strategies that are not pharmacologic include novo TTF. This also has been somewhat of a game changer in the treatment of GBM. Basically, it's an antimitotic treatment, and it selectively disrupts the division of the glioblastoma cells. There are tumor treating fields that use a low intensity, intermediate frequency of an electrical field. In clinical trials, the initial clinical trials that looked at this, it showed a cause, a mitotic arrest and apoptosis. And when added to maintenance temozolomide, clinical trials demonstrated significantly prolonged progressive or freedom to outcome survival. Now, there are clinical trials examining the benefits of novo TTF plus concurrent chemoradiation with temozolomide. And at my center, we are currently enrolling patients in this trial. And this is looking at the addition of novo TTF to those patients who receive standard treatment. So the device is, as stated, is delivered through these electromagnetic fields. There are these arrays that are placed on the patient's skull, or scalp, I should say, and these fields are directed towards the area where the tumor had been or is. The patient is required to shave their head. They have to wear it up to 16 to 17 hours. It is connected through electrodes to a battery pack, which can either be worn as a backpack or a shoulder pack. What the studies have shown is that those patients who have a 70% or greater wearing time usually have improved outcome survivals. It is not for everyone. A lot of the patients that we have introduced them to this device have either flatly declined from using it. We always leave it up to them if they would like to consider it at a later date. Some of them did not like the social stigma of wearing the device outside. Some of them did not like the fact that they had to shave their heads. Others embraced it. I've had patients who have worn it and played golf, hiked, and we had one gentleman who actually was a contractor, and he replaced windows while wearing the device. Not something we had recommended, but he was a rather headstrong individual. I mentioned in our second case presentation that the patient had utilized the ketogenic diet. So this has undergone a lot of investigation. It's a very rigorous diet. If followed completely, and not a modified ketogenic diet, but basically this is the premise of why they think the ketogenic diet works in patients with GBM. All tumor cells have altered dysregulated metabolism. This is not just for GBM, this is in any tumor cell. So ketogenic diet or avoidance of carbohydrates in other types of cancer is also employed. We also know that these tumor cells have an increased reliance on glucose. Well, all of our cells, even our normal cells, are very reliant on glucose to maintain normal cellular metabolism. So what the evidence from those individuals who have consumed or followed a ketogenic diet is that it demonstrated treatments affecting cellular metabolism, and that it may improve outcome survival and improve the current therapies. So it's mainly used, the diet is mainly used as a secondary adjuvant therapy in the treatment of tumors. Basically, I'm quite sure every one of you know what a ketogenic diet consists of, but it's a high fat, low carbohydrate or no carbohydrate protein diet. Clinical trials have demonstrated possible effectiveness when used with other adjunctive therapies such as bevacizumab, temozolomide, radiation, versus even as a monotherapy, although the latter is not something that would be highly recommended. The use of the ketogenic diet is primarily based on tolerability and feasibility of the diet. The patient that in our second case presentation, she was religious about following it. She had a tremendous weight loss with it. Prior to her progression, she had been enjoying several months of disease-free progression, and she and her husband had taken a lifelong trip to Italy, primarily in the Tuscany region. And it was a trip where they learned how to cook Italian cuisine. She consumed a lot of carbohydrates. And it was soon after this that she progressed. And she always blamed her progression on the fact that she enjoyed all of that pasta and pizza while in Europe. Clinical trials. So currently, as of the recording of today, there are 320 active and recruiting clinical trials focused on GBM internationally. Most of the studies are directed at methylated GBM versus unmethylated GBMs. Some studies are directed at recurrent GBM, which there hasn't been a lot of that out there. The investigations that are ongoing examine the effectiveness right now, as I mentioned before, of Novo TTF plus radiation and concurrent temozolomide. There's further investigation on ongoing uses for immunotherapy and other targeted chemotherapies. And there's a couple of studies looking at maximum surgical resection with intraoperative XRT that are being viewed. But you can go on to the website, clinicaltrials.gov. You just simply type in GBM and you can see the array of clinical trials. There's 320 active. There was a total of over 1,000 trials in GBM at various stages. I wish to thank you for your time, and I hope you found this presentation today on GBM helpful. If you have any further questions, please do not hesitate to contact me directly through Donna.Avanecean@hhchealth.org. Thank you.